All right, good morning, everyone. Welcome to the second live case from the first affiliated hospital of Harbin Medical University. And today we'll get back to where we started. We'll focus on the coronary interventions.
Good morning, everyone. Here is Wang Lingyu. First, I would like to introduce the patient. He's a 69-year-old male, and his chief complaint is paroxysmal chest pain for 1 year and worsened for 7 days. Main risk factor is diabetes for him. He is a non-smoker. His echo showed us an injection fraction of 62% and with no abnormal motion. So here is his ECG. We can sinus rhythm with inverted T wave in lead 2, lead 3, lead EF, and lead V3 to V6. But unfortunately, we find atrial fibrillation. Here is his laboratory data. So we can see that his glucose is a little bit higher than normal, and the TNI of this patient is positive. This is a baseline angiography of this patient. We can see that the RCA was total occluded at baseline. And there was a severe stenosis in the distal left main and proximal LAD with moderate calcification. At the proximal LCX, there was a mild stenosis. From the cranial side, collateral branches from LAD to distal RCA. Next, we have calculated the syntax score for this patient. The result is 29. According to the evidence-based medical proof, CABG is the first choice for this patient, but the patient refused to do a CABG and choose a PCI procedure. We have a filter XA wire called the occluded layer, and we put two stents in the RCA, and now this is the final record for RCA. Indeed, we have introduced the Chinese original functional tool QFR for several cases. We all know that the Favor 3 China study is very famous, told us among the patients undergoing PCI, a QFR guided strategy for line selection improved 1 year clinical outcomes compared to the angiography guidance. The QFR for LAD in this patient is 0.42, and we should deal with the lesion. So, and the QFR platform also give us a virtual stenting suggestion. The AI suggested that we could choose a short stent from the left main to the proximal LAD, and the residual QFR after stent could be 0.94. We seldom got a perfect post dilation. So I think 0.94 is enough for the patient. We also have test the lesion at proximal LCX. The isolated QFR was 0.83. The patient also finished the CT before this procedure. There was severe stenosis at left main with calcification. If we see we can see that there is single calcified plaque with 90-degree to 180-degree arc. I will introduce the intelligent visualization system for it's really a useful tool for our PCI operators. We can see that in this patient, there's a calcified plaque in the left main to the proximal LAD, but it's not a 360-degree calcification.
All right, thank you for the introduction. I think today we got a very complex case, C2 plus multivessel disease. And the first time we treated the C2 lesion in RC, right now we are still left with a very challenging left main bifurcation. So before this procedure, Dr. we have done enough preparation. We get the information we need. So what's your strategy for this patient?
We know that this is a cheap case. So this time we were prepared to make our effort to deal with the left main bifurcation lesion. We know that single stent strategy is superior to the two-stent approach. So according to the Medina classification, this lesion should be classified as 110. According to the characteristics of the lesion, we decided to use QFR for functional elevation. We want if the LAD to LM crossover stent implantation, we will check QFR of circle again. According to this data and the angiography results, we then decided to next we should do. This is today's coronary angiography. Left distal left mean severe stenosis. This is cranial position angiography. This is the RCA results. Okay. Just now, Dr. Shi has put two wires advanced LAD and RCX, and we use the common balloon to predilate at the distal RM.
All right.
Okay.
But I think after the pre-treatment, the stenosis in LD looks much better. So right now, I think the lumen is big enough to deliver the IVUS catheter. So since this is a left mean bifurcation lesion, and Dr. Sheng, you want to choose the IVUS imaging test, right?
Yes, I will use IVUS.
Yeah, I think for IVUS and OCT, they have their pros and cons. But for left mean, because left mean is usually very big, so you prefer to use IVUS. I think that's a good choice. We can have a better understanding of the lesion, whether the calcification is severe and the arc of the calcification and the length of the calcification. So IVUS is super important for this lesion.
Dr. Wang, please show the result of imaging.
Yeah, and so far, and we can see that in the mid LAD, there's a heavy plaque burden, and in the proximal LAD, there's a little there's calcified plaque in the 3 o'clock LAD, and this part of left main, we could see that there's some superficial calcified plaque. This is a distal part of the circ, quite heavy plaque burden, and this is the ostium of the circ. The lumen area of the circ ostium is 6.78. So I think the provisional strategy is right for this patient.
All right, Dr. Wang, you know what? I think from the IVUS image in LAD, because in some parts, especially in the proximal LAD, I saw severe calcification. In some parts, maybe the arc is almost 270. So what's the best strategy, for this kind of calcification? You still go with the cutting balloon? You're not thinking about like the use of ROSA or the AVL?
Indeed, the previous studies have told us if the IVUS has showed us calcification which arc is more than 270 degree, we should choose the active rota. So these calcified plaques are superficial, so could be damaged by the cutting balloon or scoring balloon. If we could use a cutting balloon to make some fracture, it will be enough.
Yeah, I got you. Because I
Yeah.
think
That's true.
in our own experience for this kind of lesion, we can try the cutting balloon first.
Yeah.
If it works, maybe we don't need to use Zota or AVL.
Yeah.
But if it doesn't work, maybe we need more, maybe other like traces to treat with this kind of calcification.
Cutting balloon cannot advance to the left main distal.
Mm-hmm.
So we change another scoring balloon
Mm-hmm.
to predilate.
I think the cutting balloon has a bigger profile. That's why for this kind of tight lesion, it's kind of hard to deliver the cutting balloon.
Yes.
Dr. Wang, I think you have been doing the interventional procedure for so many years. So based on your own personal experience, what's the difference between scoring balloon and cutting balloon?
The cutting balloon, we all know there's 3 knives on the balloon. It can predilate the lesion more effective. In my mind, actually, we always have some difficulty to deliver the balloon to the lesion.
Your personal choice is you always try the cutting balloon first. If it doesn't
Yeah.
work, in scoring balloon
Yeah.
with the smaller profile. Let's see, Dr. Sheng, are you still going to try the cutting balloon after the scoring balloon?
Yes, we advance the cutting balloon.
Okay. When there's severe calcification, it's always hard to treat this kind of lesion.
Still
Okay.
uncrossable.
Then what's next?
NIC balloon again.
And this time you choose bigger one, and I see
No,
the same
the
size.
same size.
So last time you gave like 10 ATM, and this time you increase the pressure to 12
Yeah,
or much higher.
trial of 14.
Mhm. Yeah, I think this is a very old patient, and
Okay.
he has some risk factors, and so those could be the reasons for this patient to have atrial fibrillation. And maybe because the patient has been
7,
hospitalized for a few
8,
days, and we
9,
also gave the patient some
10,
fluids.
Yeah.
That may also increase the
12,
risk of getting atrial
14.
fibrillation. 14 ATM.
Yeah,
So right now we still cannot deliver the cutting blue through the lesion. So Dr.
IVUS.
Sheng, she wants to do the IVUS again
Uh,
to see
no,
what is going wrong.
I will check the IVUS.
but we can see that the same side NSE balloon cross the layer easily.
Mhm.
Yeah,
We all know that the NSE balloon, the cutting line of the NSE balloon is to the tip of the balloon, so it can cross the line easily than the cutting balloon.
okay.
And the knife is really a little bit
IVUS.
bigger than the NSE
Okay.
balloon or the skull flex.
I think the calcification is the enemy. That's the reason why we cannot deliver the cutting balloon. So Dr. Wang, can you interpret the IVUS image?
Yes, here's some small fracture caused by the NSE balloon. I think we could choose the NSE balloon again and dilate it.
We could see there's some fractures, but that's not enough. And this time, I think Dr. Sheng will try a bigger NSC balloon. So now, what's the size of the balloon this time?
0.0.
But from the angio
9,
image, I think
10.
the NC balloon
Trial.
can be well expanded.
Yes.
That indicates maybe the calcification is not that severe. Dr. Sheng, do you think the pre-treatment with the NC balloon is good enough? Right now, it's the right time to put the stent?
From the angiography,
Mhm.
the balloon is
Well expanded.
very expanded
Maybe now we
So,
can try to put the
to
stent.
put the stent.
Yeah.
Yeah.
I think maybe we should two stents in LAD and left main. In the our side, you can see that there's heavy plaque burden and we
Okay.
cannot find a
Okay.
normal.
Okay. The first stent we should select which size? 2.5.
Yeah, I think 2.5 is a good choice.
So after the AVAS, now we decide to use two stents, right?
The first stent should be cross over
Diagonal.
the first diagonal.
Yeah,
Two diagonal
the second diagonal.
at the mid of the two diagonal.
Yeah,
Is it good?
Yeah, I think
yes,
it's in
it's
a good
good enough.
position. Yeah.
Okay. Delete.
So what stent are we using? What stent do we
Re-
choose?
Resolute.
Resolute. Okay.
Yeah, that's a little bit. Okay.
Okay. Delete. Okay. Done. And it is 18. The second stent should be to the ostium of RM.
No, I think the ostium or the left main is good enough. 18 or 20 or both okay.
20. 3.0.
3.5.
So for the second stent, 3520, we have to carry the proximal RD to the distal left knee. So those two stents, they have to be overlapped a little
Overlap,
bit,
yeah.
right? Yeah.
Yeah. 2 millimeter overlap.
Okay.
Okay.
Test to overlap.
No, maybe a little bit further.
Okay.
Okay.
Proximal okay. Andrew, do we need to put the stent to the ostium?
No.
So we have to make sure whether or not the ostium of the left knee should be covered.
Yeah.
So recheck the ALICE.
Yes.
I think the lumen is big enough.
Okay.
I think you can put the stent a little bit further.
Okay. Andrew, it's good.
Yeah. That's like
Uh,
what you mentioned before. The calcified plaque influence
Delete
stent.
again.
I see, because some parts of the stance is not well expanded.
Slow.
Yes.
This time we could perform QFR of X
Mhm.
circumflex.
So right now, when Dr. Sheng is doing the post-dilatation with the NC balloon, so is there someone who's doing the QFR for circumflex?
Yes.
As Dr. Sheng mentioned, after the functional assessments of circumflex, after the stenting in the left knee and RED, and then we'll know whether or not we need to treat the circumflex. Let's just wait for the QFR results. So this is a bigger balloon, right?
This is a 3.5. Angiography. We need a 3.0. Any position? RAO crino. Okay.
Dr. Wang, for this kind of bifurcation lesion,
Yeah.
because this is Dr. Sheng's strategy. After the stenting in the main vessel, he wants to do the QFR of the side branch, and then he will decide his next step.
Yeah.
But for some operators, for this kind of bifurcation, after the stenting in the main vessel, they always do the KBI. I know
Yeah.
this is kind of controversial, right? Whether or not to routinely do the KBI. So what do you think of this procedure?
In our team, we not always do the KBI.
Mhm.
We all know that the previous studies have told us routine KBI after the main branch stenting
Mhm.
could not give the patient
Okay.
more benefit.
Mhm.
So in our team, we only use the KBI when
Trial.
the flow of the side branch
14.
is under Kimi 3 degree,
Okay.
or there's a dissection
Mhm.
more than gravy, or the FFR or QFR is less than 0.8. The KBI will give the patient more risk to have
16.
a dissection in the side branch.
17.
Yeah, I see. So
Yeah.
it depends on the lesion characteristics.
Yes.
Okay.
Yeah. So after the post dilatation, I think from the angel, the stance looks okay, right?
Yeah.
But we are not sure about the details. Let's see the IVUS image.
Okay.
Here's the
Good.
first stent.
Yeah, the first stent. We need a post dilation of the first stent,
Yes.
but the position is quite good. Second one is wheel expansion.
We have post dilation.
Yeah, but the ostium of the stent should be dilated again.
Okay. 3.5 is enough?
No, I think much bigger. I think at least 3.75.
So Dr. Sheng, you want to do the post dilatation of the first stent first or the second stent
The
first?
first stand.
Okay. IVUS again.
3.75. Post dilated ostium of the
Second
second
stand.
stand.
You want to choose a bigger balloon to do the post dilatation for the
Yeah.
second stand.
Is it
Why?
right? Look,
Okay.
okay?
Yeah,
Yeah,
that's the right
Okay.
place.
Okay.
I
So
think Dr. Wang, the audience
Okay.
asks us a very, very good question.
yeah,
So they want to know, should we consider the use of IBP or other circulatory supportive devices? So
Yeah.
what's your opinion?
in this patient, during the first PCI procedure, we have a IBP standby. In our mind, we all know that there's a collateral branch from the LAD to RCA.
Mhm.
So the left coronary artery is very important to this patient. Even here we can see is stenosis more than 80% in left vein. This may be the corporate line for his TNI, but we should finish the RCA first because the RCA CTO is not so complex and it's much safer for
IVUS,
the
please.
patient to do the RCA.
Okay.
And if we do the left vein PCI first, of course, I will choose mechanical circulation support. And even I think if we do the left vein PCI first, IBP is not enough. Maybe in parallel or ECMO.
Looks very good. Patient good.
So after the post dilatation, I think both stents are well expanded.
Yeah.
Final angel, and then we'll finish this procedure.
Yes. Crino.
What do you think, Dr. Shen? What do you think of the final angel?
Not good.